function as a buffer pad or cushion function because it is not that hard and rigid. So so the cost is also expensive, and it takes a lot of lab technician times to do the pectone bridge. So during the professional stage, I like to use the packing method and CNC material only for a reason: it's repairable. In professional stage, patient will wait for like over 6 months for implant or seal integration. So everything could be happened during these 6 months. So most often seen is the resin fracture. So choose the one material which could repair easily in your chair side is very, very important. And for the definitive prosthetics, here are summary and compare with the aesthetic, lifetime, durability, biocompatibility, repair, and cost. As you can see here, different materials take high score in different aspects. So there's no best material, only which is suitable for patient. And we can see the cost, the price the technician charge from me in Taiwan. Okay, so last part is the complication. Complication include the failure of one or more implants to osteointegrate, or aesthetic miscalculation involving the gingival exposure or soft tissue inflammation and infection from the oral hygiene. But however, the most common type of complication is denture fracture. So here we'll see how it happened and how to avoid. So a complication can be classified as surgical related or patient related. Most common seen the surgical related is bone loss between two implants distance is not maintained. Another common surgical related complication is insufficient bone reduction. The surgeon should ensure that no transitional line between gingiva and prosthetic will be visible when patient smiles. It would be nightmare when the complication is happening. If it's visible, the bone requires more reduction to hide under the lip. And next is patient related. Sometimes happen when patient doesn't clean the teeth well, or they have poor oral hygiene and doesn't come back for the dental checkup, routine checkup. And next one is the prosthetic related. For the prosthetic-related complications involve many situations, like prosthetic resin fracture, which most common seen, and occlusal wear, screw loosening or fracture, or we do the miscalculation of vertical dimension or cantilevers, and even the misfit of our prosthesis, and lost postural support. For the prosthetic fractures, sometimes happen with artery fracture from the titanium sleeve, especially in professional stage. When it happens, we need to take serious consideration to final prosthetics. We must to check the design of our suprastructure if it is extended enough to support the resin or support the zirconia. And the occlusion should be checked and night guard should be used. Second one is the screw loosening. It happened when the patient had bad habit, like chewing gum or like to chew the really hard things. It gives too heavy occlusal load. The solution here is to quit the bad habit and screw retightening or change the new screw. And next is occlusal wear. It's usually seen when the operate denture against ceramic antagonist. So we have to choose the right material to fabricate the final dentures. Okay, and one very serious problem is miscalculate the restorative space, including the vertical distance, horizontal and sagittal plane. Because it's irreversible procedure, it could make very bad consequence. And next one is misfit or non-passive fit. It may cause the prosthetic fracture or abdomen fracture. Screw front loosening is often seen. To solve this problem is just redo your dentures and make sure its passive fit is achieved. And next is occlusal wear. When we lost the postural support, it may reduce the vertical dimension, and heavy force occlusion may transfer to the anterior teeth, causing the anterior teeth fracture. So the treatment is increase the vertical dimension by changing the new posterior teeth when lost posterior support. Okay, so let's talk about the prosthetics clinical procedures. Okay, these are some software and navigation systems we normally use and design for the pre-surgical planning, like DTS software, 3Shape, Implant Studio, Sky, Navigant. And here I will show you three methods I introduced for the dentures. The first is a traditional method, and second is a semi-digital method, and third is digital method. For the traditional method, when we start like this full arch implant case, first we do the model surgery. We trim the stone, we trim the models, and make the individual tray. And next step, we can take the impression by open tray impression coping, then mount it to the articulator. And we can do wax up and packing the denture. In this method, we can get the tissue information, implant information, and maxillomandibular relationship. Another semi-digital method is that we design the implant and denture in the software first. Then we produce the bone surgical guide for the surgeons. After that, we take the impression and just connect the denture with the titanium sleeve, and like do the polish and flatten the dentures. And for the digital method, the difference here is that we don't print in the stent. We output the design STL file to the dynamic systems like X-Guide or navigation guide. At the same time, we can CAD-CAM the denture and lift an opening of temporary abutments. So after the implant placement, we can deliver the denture. This is a case we produced two stents, which is tooth guide and bone guide. We try the tooth guide first and extract the remaining teeth. Then we place another bone guide to do the implantations to make sure the position is in the same place. And then we deliver the denture in the same days. And this is a digital method. We design the implant and denture first in the software, then use the navigation systems to do the implant. At the same time, we produce the denture with living implant holes. So we can do the pick up, deliver the dentures. Okay, so that is I just mentioned before, the comparison of the interim dentures. Skip this. Okay, so for the definitive dentures, the final dentures, here I will prepare the workflow for traditional and digital method for making the final dentures. In the traditional method, patient come for the primary impression, and we do the secondary impression, we do the model verification, file registration, wax up denture, try-in, and deliver the final dentures. But in digital method, we can have many kinds of scan body or scan rods to do the oral scan, and also scan the temporary dentures. Then the second phase, we need to verify the model and if it's any misfit. And third visit, we can have our trial denture. And in the fourth visit, and we can deliver our final dentures. Okay, here are the workflow we use for the traditional one, like we use the closed tray impression coping, like take primary impression, and use the open tray coping and resin chip to connect. And we separate the chip, connect that again intraorally, and then we take the final impressions. And here we see the verification chip. We try the verification chip on the model and intraorally to make sure its positive fit is achieved. And then we can design the trial denture and check the appearance and occlusion with the patients. And if there's no problem, we send to the technician for the the metal bar making, and we can do the make crown individually with the porcelain gingiva. For the digital meta workflow, first appointment we make the impression by digital scan. With the STL file, we print the model and make the verification jig. In the second appointment, we connect the jig to check modify the master cast. If there's any misfit, we have to adjust if it's not fit. And then the denture we can design, and we can wax up and do the wax up trying, and wax up with the superstructure trying, and deliver the dentures. So, like the first, we do the intraoral scan. We put on the scan body and scan all the information we need: opposing teeth and bite, and even the entering dentures. And then second, we print the 3D model with analog inside and make the verification jig with the temporary abutment and resin. And then remember to scan the entering denture, because entering denture provide a lot of information to the lab. So actually we can scan in the first appointment. Okay, so we connect the jig together intraorally with the pattern resin, and also take the bite registration in this appointment. We also can wash some silicone material under the jig to capture the ridge and the gingiva shape. And we check the replica under the loop, see the analog or replica if there's any gap between the connection. And we can also replace the silicone tissues. And then we mount it to the cast, mount it to the articulators. And we can input the entering information to software, which we previously scan, and try to adjust and correct the appearance. After that, we can print the trial denture to the patient to check the aesthetic and the occlusion. If there's no problem, we send back to lab for the bar type design and CAD-CAM. Then we CAD-CAM the zirconia bridge and cement with the metal bar inside. And we do the stand and we do the glass. So the final prosthetic is done and delivered to the patients. Okay, so one of the success key point in digital impression. There are many scan products. Most often, they are all mature to use. But during this digital revolution, static scan is also developed very soon these years, such like the photogrammetric system. That means we only use one picture. We took one picture, and it's captured the distance between all the implants. And it's useful for me to do the entering dentures. And so it's a comparison of impression method. We can see the static scan show better accuracy than dynamic scan, and traditional scan is the last. But all of them are under 100 microns, and so it's all clinical accept. So that is the digital revolution. As we can see, the photometric for implant position measurement is accuracy within like 20 to 30 microns. And it's really precision and easy to use. In our country, a lot of prosthodontics are trying and test the static scan. And we hope in the future it could be general use and replace the conventional impressions. Okay, so let me introduce our team. And there's a sentence I believe: if everyone is moving forward together, then success takes care of itself. So here I show our works. Our team have done like over 100 full arch rehabilitation cases. Some of them are easy, and some of them are difficult. And patients are our best teachers. I always learn from the patients, the cases. And here we can see the many different situations. Some of them are edentulous, some of them are partial edentulous. But no matter what we are facing, just be responsibility to take good care of them and carefully, step by step, from surgical part to the prosthetic part to do the well, and then you will get a good result. And sometimes I think prosthodontists are like architects. We build up the teeth in the patient's mouth, and sometimes we are scientists. Sometimes we are artists. We design, we plan, we draw, and sometimes I think I'm a photographer. I take the good pictures. All we try to do is making the teeth look natural and look aesthetical. I also believe that we are not only changing the patient's teeth, but we change their life. I feel very happy to see the patient smile again. Okay, there are my best teammates, Dr. Zhang, our surgeon, but now he's performed her presentation in another idea branches. And Dr. Zhang always perform a good surgery and take good care of his patient. And Mr. J is not here, but is a perfect dentistician. I always communicate with me and discuss about the material, discuss about is any possibility to do the better, to do the faster, and we try a lot of errors. We just want to the patient get a good result. And also the dental assistant, Ms. Chen, just behind you guys. Without a good dental assistant, the patient, the doctor, the technician cannot go really well. And I'm from Taiwan. This is Taiwan. Taiwan is an island. We situate in the East Asia at the edge of the Pacific. We have variant of terrains, forest, mountain, beach, marine, and the people from Taiwan are kind. We welcome you to visit and travel here. Thank you for your attention.